Welcome to the Deep Dive, the show where we take complex, sometimes really personal topics, and we try to unpack them into those essential, super digestible insights you need to feel truly well-informed.
Mhm.
Today, we're diving headfirst into a journey that touches the lives of so many people. The intricate and often really challenging path to starting or growing a family when conception isn't straightforward.
That's right. And our focus for this deep dive is, well, it's a really comprehensive look at fertility treatments. We're going to systematically explore the various medical options, the emotional side of things, what each treatment actually entails in practical terms, what to expect.
Yeah, like the day-to-day.
Exactly. And their success rates, which vary a lot, the often, frankly, staggering associated costs, and maybe most importantly, the profound emotional and psychological landscape that really comes along with this intensely personal journey.
We're really talking about the full spectrum here, aren't we? From like the foundational fertility medications and maybe targeted surgical interventions.
The first steps for many.
Right. All the way through the more advanced reproductive technologies like intrauterine insemination or IUI
Yep.
and in vitro fertilization, which everyone knows is IVF,
The big one, yeah.
right up to third-party assisted reproduction options, things like donor eggs, sperm, embryos, and even gestational surrogacy.
Exactly. And our mission today for you, our listener, is really to try and arm you with a clear, thorough, and importantly, empathetic understanding of these treatments.
Yeah, empathy is key here.
Absolutely. We want to distill the most important nuggets of knowledge from our sources so you can navigate this intricate world feeling not just equipped, but hopefully empowered and, without feeling totally overwhelmed by all the information.
Hopefully we can provide some genuine aha moments, maybe some surprising details along the way too.
Definitely. And to do that, we've pulled together an extensive stack of sources, mostly from BabyCenter. What makes these sources particularly useful, I think, is their blend. They have medically reviewed articles, so the facts are solid.
Right, the expert view.
But they also weave in these raw, personal anecdotes from their community members.
The real-life experience.
Exactly. And that combination gives us a really holistic perspective, marrying the essential medical facts with the very real, deeply human experiences of people actually living through this.
Okay, let's unpack this then. To really get a handle on fertility treatments, I think we first need to define what infertility actually is. Understand the scope of the challenge. It seems like it's more common than many people might realize.
It really is. Medically speaking, infertility is defined as the inability to become pregnant after at least a year of actively trying to conceive through unprotected sex.
A full year, okay.
A full year. And if you're listening and that definition resonates with your own experience, please know you are absolutely not alone. Our sources indicate this isn't some rare issue. It affects a significant portion of the population specifically, somewhere between 10% to 15% of couples in the United States.
Wow, 10 to 15%. That's a lot.
It's a substantial number. It really highlights the quiet struggles happening for many couples.
That statistic really puts it into perspective. And I think it's so crucial to understand that this challenge is rarely, if ever, just one person's fault. Right?
Absolutely not. That's a really damaging misconception. The responsibility, or maybe the biological hurdle, is often shared. Roughly a third of all infertility cases are actually attributed to issues affecting both partners simultaneously.
A third, okay.
Yeah. Or sometimes the precise causes simply remain unknown, falling into that category of unexplained infertility, which can be incredibly frustrating.
And can imagine just not knowing why.
Exactly. And the remaining two-thirds, they're actually quite equally split between identifiable male fertility problems and female fertility problems. So it really underscores that this is overwhelmingly a shared journey, not some individual burden to carry alone.
That's such an important point to emphasize. Now, amidst what can feel like a really isolating struggle, is there good news? Is there hope?
Yes, there absolutely is. And what's truly fascinating here, and offers a significant beacon of hope, is a statistic cited repeatedly in our sources. They highlight that 65%, nearly two-thirds of couples who pursue medical treatment for infertility, successfully achieve pregnancy.
65%.
Yeah.
That's much higher than I might have guessed.
It is. It's a powerful statistic that often gets overlooked. It offers immense encouragement for anyone feeling discouraged or overwhelmed by that initial diagnosis. Treatment often works.
Okay, so knowing what infertility is, medically, statistically, that brings us right up against the very real and often kind of unspoken emotional impact this whole journey can have. It's definitely not just a physical thing.
Oh, absolutely not. You've hit on such a critical point. The emotional pain of infertility is incredibly complex. It's multi-layered, and it impacts both women and men deeply, though sometimes in different ways.
Mm.
Our sources describe it really powerfully as an emotional roller coaster.
Mm.
It's this repeated cycle of soaring hope, followed often by just crushing disappointment.
Right, month after month.
Exactly. Think about that agonizing monthly wait for a period that signals, yet again, another failed attempt, another dream deferred. That repetitive cycle can be incredibly, incredibly grueling.
And here's something that really struck me, something kind of heartbreakingly real from the sources. Studies suggest that women who are grappling with fertility problems can experience levels of anxiety and depression that are comparable to those undergoing treatment for serious life-threatening conditions.
Yeah.
We're talking things like cancer, heart disease, or HIV.
Hmm.
When you hear that comparison, it just raises this huge question. Given that immense emotional weight, why don't we talk about this more openly? Why is there still so much silence around something causing such profound distress?
That silence just compounds the stress, doesn't it? And the emotional toll isn't just some vague feeling. It shows up in very specific, intrusive ways that really impact daily life.
Like how?
Well, for instance, the very act of intimacy. Sex, which should ideally be spontaneous, pleasurable, a connection, it can be utterly transformed. The need for timed intercourse, meticulously planned around ovulation calendars, just strips the sexy right out of sex. It turns it into this scheduled obligation, a chore almost.
Wow, yeah. That sounds incredibly difficult.
It puts a huge strain on a couple's relationship, naturally.
I can only imagine. And then there are the questions, right?
Yeah.
They're often well-meaning but relentless questions from friends and family.
Oh, definitely. So when are you having kids? Or don't you want to start a family soon?
Yeah.
These seemingly innocent questions can inadvertently pile immense pressure onto people, forcing them to constantly explain or deflect really deep personal struggles. The sources even offer some empowering advice here. Give yourself permission to skip painful events, like baby showers if you need to.
That's actually great advice. Protect yourself.
It is. It's about protecting your own mental health, setting boundaries during this incredibly vulnerable time.
And beyond the social and emotional strain, there's the financial piece. That looms large, doesn't it?
It's immense. For many, it becomes a monumental barrier. Fertility treatments are notoriously expensive, and a huge chunk of the costs often fall outside of standard insurance coverage. This financial strain creates overwhelming pressure on relationships, just adding another layer of stress.
We're talking serious money, right?
Absolutely. Consider that a single IVF cycle alone can easily cost upwards of $20,000, often more out of pocket. This isn't just a medical journey. It's a significant, often crushing financial one. It can feel like climbing a mountain, demanding sacrifices from every corner of your life.
And it just takes over everything, doesn't it?
It becomes all-consuming. The whole process of trying to conceive, especially with medical help, can morph into this relentless mental fixation. It dominates your thoughts, your conversation. It disrupts work schedules, social lives, even hobbies disappear. Every single aspect of life, what you eat, how you exercise, travel plans, everything gets meticulously weighed against its potential impact on fertility. This constant vigilance, this analysis, it leads to overwhelming mental and physical exhaustion. It makes it incredibly hard to find moments of just normalcy.
So how does this stress actually show up? What are the signs people should look out for in themselves or their partner?
Yeah, the signs can manifest in various ways, sometimes subtly. Things like persistent sadness or feelings of depression, a noticeable loss of interest in activities that used to bring joy, significant relationship strain, maybe more arguments or distance, generalized anxiety, maybe even panic attacks, difficulty concentrating on work or other tasks, noticeable changes in sleep patterns, sleeping too much or too little, or eating habits.
Right.
Sometimes, unfortunately, an increase in substance use as a way to cope. And in really severe cases, the emotional burden can become so intense that thoughts of self-harm might arise. That's when immediate professional help is absolutely critical.
Given this profound impact, it makes sense that the sources really stress getting professional help.
Absolutely. They strongly underscore the critical role of professional support. They emphasize seeking out mental health counselors, therapists, or psychiatrists who have specific experience, specific training in infertility.
Ah, that specialization is important.
It really is. These professionals can provide tailored support, They understand the unique relationship strains, they can help process the complex medical options, and crucially, they help build resilience and develop effective coping mechanisms. And support groups where you connect with others on similar paths are also highlighted as just invaluable resources.
But the message is, don't go through this alone.
Absolutely not. You do not have to carry this weight by yourself. Understanding this whole intricate emotional landscape is so vital because it underpins every single decision made when you start exploring the medical treatments. This emotional framework is going to be key as we now start to unpack each of those treatment options in detail.
Okay, so now that we've really got a sense of the emotional and practical landscape of infertility, let's pivot to what many people think of first when they consider getting help.
Right.
The actual treatment options. And we'll start with what's often the very first line of approach, fertility medications.
Right. Fertility medications primarily work by regulating reproductive hormones, focusing particularly on triggering the release of eggs in women. They're quite versatile because they can be used as standalone treatments, a simpler, less invasive starting point. Or they can be used alongside more advanced technologies like IUI or IVF to boost their effectiveness.
Let's break down some of the common ones for women. First up, there's clomiphene citrate. People might know it better as Clomid or Seraphine. How exactly does that work?
Clomiphene basically works by tricking the brain, in a sense. It stimulates the hypothalamus and pituitary gland, the hormone control centers, to release more FSH and LH. Those are the hormones critical for stimulating the ovaries. This hormone surge then triggers the development and release of one or more eggs. In terms of success, it's pretty good at doing its job. About 80% of women who take clomiphene will ovulate, often within the first 3 months.
80%, wow.
Yeah, for ovulation. And of those who ovulate, about half will conceive. If you look over a longer period, say 6 months of treatment, it results in about a 20–40% live birth rate. So it's a very promising first step for many.
And what's the cost look like for clomiphene? And are there significant side effects?
It's relatively affordable, typically ranging from maybe $25 up to about $179 per cycle. So quite accessible. As for side effects, they're generally manageable, but can include things like hot flashes, some abdominal bloating or discomfort, breast tenderness, noticeable mood swings, headaches, and in rarer cases, even some visual disturbances.
Okay.
It's also important to know clomiphene increases the odds of having multiples, mostly twins, by about 10%. That's because it often stimulates more than one egg to release.
Right, makes sense. Okay, next there's letrozole. I understand this one's particularly useful for certain conditions.
Yes. Letrozole is another oral medication, also works by regulating hormones. It's been found to be especially effective for women diagnosed with polycystic ovary syndrome or PCOS.
PCOS is so common.
It's a leading cause of female infertility because it messes with ovulation. A significant study of women with PCOS showed that about 28% had a live birth over 5 cycles using letrozole, so it's a really vital option for that group.
And cost and side effects similar to clomiphene.
Cost is quite low, often around $20 per cycle. Side effects are similar. Yeah, most common are hot flashes, maybe some joint or muscle pain. Less common things could include headache, anxiety, confusion, maybe some sleep issues.
Okay, then we move up a level, it sounds like, to gonadotropins. These seem a bit more intense than the pills.
They are, yeah. Gonadotropins are injectable drugs. They work by directly stimulating the ovaries to produce multiple eggs rather than just 1 or 2.
Direct stimulation.
Exactly. They include different types like HMG, human menopausal gonadotropin, FSH, urofolitropin or recombinant FSH, and HCG, human chorionic gonadotropin, which is often used as the trigger shot to time that final egg maturation and release.
And the process is more involved too, right, with injections and monitoring?
Definitely more involved. It requires daily injections, usually for about 7 to 12 days. Then comes that critical HCG trigger shot, timed precisely about 36 hours before either egg retrieval for IVF or timed intercourse IUI.
Okay.
And this phase demands frequent monitoring at the clinic, regular blood tests to track hormone levels, and ultrasounds to actually measure the growth of the follicles, which hold the eggs.
That sounds like a significant commitment, just managing the appointments and everything. What about success rates with gonadotropins, maybe with timed intercourse or IUI?
With timed intercourse alone, the pregnancy rate is about 15% per cycle. When combined with IUI, a study found around a 7% live birth rate per cycle, but a cumulative live birth rate of almost 18% over several cycles. So it improves chances, but it's still a numbers game.
And the cost reflects that intensity, I imagine.
It does. Costs for gonadotropins vary really widely, from maybe $150 up to $5,400 per cycle. It depends heavily on the specific drugs, the dosage needed, and how long the stimulation phase lasts.
And side effects for these stronger meds, are there bigger concerns?
Yes, a few important ones. You can get injection site reactions like soreness or bruising. More systemically, things like mood swings, breast tenderness, abdominal bloating. Headaches are common. But the significant risk with gonadotropins is something called ovarian hyperstimulation syndrome, or OHSS.
OHSS, right. I've heard of that.
Yeah, it's when the ovaries get overly stimulated, causing swelling and fluid buildup. Mild cases are actually quite common, affecting 10–20% of cycles. That usually just means temporary swelling, maybe some discomfort, and it resolves with careful monitoring.
But severe cases can happen.
Severe cases are much rarer, maybe 1–2% of cycles, but they can be serious and require hospitalization due to more significant fluid shifts and potential complications. There's also a slight increase in the risk of ectopic pregnancy, where the embryo implants outside the uterus, and a very rare risk, less than 2%, of something called adnexal torsion, which is a twisting of the ovary.
Those serious risks sound scary. But what about the older concerns? The link between fertility drugs and cancer risk, like ovarian cancer. Has research clarified that?
That's a really important question, and thankfully, the recent research has been quite reassuring. Studies now show no increased risk of ovarian cancer associated with using these fertility drugs. That's a huge relief for many patients.
That is good news.
It is. However, it's still important to remember the risk of multiples is higher, with gonadotropins around 30%, mostly twins. That's a direct result of stimulating multiple eggs, and while often seen as a blessing, multiple pregnancies do carry higher risks.
Okay, so that covers the main drugs for women. What about fertility drugs for men? Is that a common approach?
It's far less common, actually. Only about 2% of male infertility cases are treatable with fertility drugs. Specifically, these drugs target a condition called secondary hypogonadism.
Secondary hypogonadism.
Yeah, it means there are problems with the hormone signals from the brain, the hypothalamus or pituitary gland, leading to low testosterone and, consequently, low sperm production. The drugs used are actually the same ones we just talked about: clomiphene, HCG, and HMG.
Interesting, the same drugs.
Yeah, though it's important to know not all are specifically FDA approved for male infertility, but specialists do prescribe them off-label when it makes sense medically.
And how long do men need to be on these? Sperm production takes time, right?
It's a long game, absolutely. For clomiphene, men usually take it for 3 to 6 months, sometimes even up to 2 years for optimal results. Gonadotropins, which involve 2–3 injections per week, can take even longer. It might be 6 months before you even start seeing improved sperm production, and potentially 1 to 2 years for maximum effect. Patience is key.
And the success rates for men using these?
With gonadotropins, for that specific condition, secondary hypogonadism, the improvement can be quite dramatic. They can boost sperm production in up to 90% of those men. But again, it takes months for those new sperm to show up.
Right.
For clomiphene, the studies are more mixed, often showing only slight improvement in overall pregnancy rates, but it's still prescribed sometimes because it's an easy-to-take pill and much cheaper than the injectables.
Speaking of cost, what are we looking at for male fertility drugs and side effects?
Costs vary. Clomiphene is pretty cheap, maybe $100 a month. HCG is around $180 a month. HMG can be much more, up to $2,000 a month. Side effects are generally mild for clomiphene, maybe nausea, headaches, slight vision changes, weight gain, changes in sex drive, dizziness, maybe some breast enlargement. Gonadotropins can cause injection site soreness, similar breast enlargement, maybe acne, and changes in sex drive.
Okay, so beyond tweaking hormones with meds, sometimes the issue is more physical, like structural problems or blockages. That's where surgery comes in.
Exactly. Surgery is a crucial tool when physical conditions are impacting fertility. It can correct congenital defects, clear blocked fallopian tubes, remove uterine fibroids that might interfere with implantation.
Right. Fibroids are common too.
Very. Surgery can also excise endometriosis tissue, which causes inflammation and scarring, or even address certain PCOS-related issues surgically.
What are the main types of surgery used for fertility?
The most common nowadays is laparoscopy. It's minimally invasive, great for things like endometriosis or some PCOS issues. They make tiny incisions in the abdomen, insert thin instruments, and a lighted camera.
Like keyhole surgery.
Exactly. Allows the surgeon to see and fix things with minimal disruption. Recovery is usually quicker, maybe some back shoulder discomfort from the gas used, possible sore throat from anesthesia, feeling sleepy. Then there's laparotomy.
That sounds more major.
It is. It's a larger abdominal incision, less common now. usually reserved for complex cases like multiple large fibroids really distorting the uterus or tubes, or if significant reconstruction is needed. Recovery is longer, discomfort for days or weeks. And finally, hysteroscopy.
What's that involve?
A lighted device is gently placed through the cervix directly into the uterus. This lets the surgeon look inside the uterine cavity and remove things like polyps or adhesions, scar tissue that might be preventing pregnancy.
So how effective are these surgeries? Do they really boost pregnancy chances?
Success rates really depend on what's being treated. For women with minimal or mild endometriosis, there's about a 40% chance of getting pregnant within 8-9 months after laparoscopy. That can climb to almost 70% by 38-month post-surgery.
Wow, that's quite high over time.
It shows the long-term benefit. For fallopian tube surgery, though, rates vary hugely from maybe 9% for severe damage to nearly 70% if it's mild disease, like a simple blockage. For PCOS, a procedure called ovarian drilling, done laparoscopically, offers about a 50% chance of pregnancy within a year.
Any real-world examples?
Yeah, one BabyCenter member shared she conceived just 1 month after her laparoscopy. It really highlights how immediate the impact can be when you remove a specific physical barrier.
That's incredible. And the cost for these surgeries?
Big range, anywhere from $2,000 to $10,000 or even more. Depends on the type of surgery, complexity, anesthesia, inpatient versus outpatient, and of course, insurance coverage plays a huge role.
Okay, so if meds or surgery aren't the right fit or haven't worked, but maybe full IVF feels like too big a leap just yet, there's intrauterine insemination, or IUI, often called artificial insemination.
Yeah.
What exactly is that?
Right, IUI. It's a procedure where they take a concentrated amount of prepared sperm, either from a partner or a donor, and deposit it directly into the uterus using a thin, flexible catheter.
So bypassing the cervix.
Exactly. The idea is to get the sperm past the cervix, which can sometimes be a barrier, and give them a head start, get them closer to the egg in the fallopian tube where fertilization happens. It's a method with historical roots, but modern IUI is much more refined.
Who's a good candidate for IUI? What problems does it help with?
IUI can be really beneficial in several situations. Often recommended for couples dealing with low sperm count or poor sperm motility where the sperm just aren't swimming well enough.
Makes sense. Give them a lift.
Precisely. It's also a common approach for unexplained infertility where they can't pinpoint a specific cause. Also helpful if there are issues with cervical scarring or mucus abnormalities that impede sperm movement, or if there's severe pain during intercourse preventing natural conception, or issues with ejaculation or erection.
And for same-sex couples or single women?
Absolutely. It's a very common and effective choice for single women or lesbian couples using donor sperm to build their families.
Let's walk through a typical IUI cycle. What's the process like for the patient?
Okay, so an IUI cycle usually lines up with a woman's natural cycle, spanning about 2 weeks. It starts with egg production. The ovaries might be stimulated with fertility drugs like clomiphene or gonadotropins to produce one or maybe a few mature eggs. Or sometimes they do a natural cycle with no drugs if ovulation is regular.
Then you need to know when ovulation happens, right?
Crucial step, tracking ovulation. Patients might use ovulation predictor kits at home, or the clinic uses ultrasound monitoring and blood tests to pinpoint that luteinizing hormone, LH surge, which signals ovulation is about to happen.
Okay, LH surge detected. Then what?
Then comes the sperm preparation. Once ovulation is detected, or maybe a trigger shot is given to time it precisely, the sperm sample partner or donor is washed in the lab.
Washed.
Yeah, it's a process that separates the sperm from the seminal fluid and concentrates the best, most motile sperm into a small volume of fluid.
Gotcha, concentrating the good swimmers.
Exactly. Then comes the insemination itself. The concentrated washed sperm is painlessly inserted directly into the uterus using that thin catheter. This usually happens 24 to 36 hours after the detected LH surge or the trigger shot.
And then the waiting game.
The infamous 2-week wait. About 2 weeks later, the patient takes a pregnancy test to see if it worked.
How many IUI cycles do people typically try before moving on?
Well, the insemination itself is quick, just minutes. But the lead-up with monitoring takes about a week. Many patients might try, say, 3 or 4 IUI cycles before their doctor suggests considering other options like IVF, especially if they haven't conceived.
And age plays a role here, too.
Definitely. For older women, maybe late 30s or 40s, doctors might suggest moving to IVF sooner, just because egg quality declines more rapidly with age and time becomes more critical.
What are the success rates like for IUI? Does it vary a lot?
It really does depend heavily on the specific fertility issue and the woman's age. For unexplained infertility, a natural IUI cycle might have a 4-5% pregnancy rate. Add fertility drugs, and that jumps to maybe 7-16% per cycle. The American Society for Reproductive Medicine, ASRM, reports overall rates can be as high as 20% per cycle in some cases.
So it boosts chances, but it's not guaranteed by any means.
Not at all. And we heard a really powerful story from a BabyCenter member, Rainbow Mom Sarah. She shared her long journey, 2 rounds of IUI, a heartbreaking pregnancy loss, then another 2 IUI rounds over 3.5 years before she finally conceived her daughter. It just illustrates the incredible emotional endurance this path can require.
Wow. That's real perseverance. So summing up IUI, what are the main pros?
Okay, pros. It's significantly less invasive and generally less expensive than IVF, making it a more accessible first step for many. It definitely improves conception chances for certain male factor issues compared to just timed intercourse. For unexplained infertility, it often does better than just using fertility drugs alone. And a big one for some people, fertilization happens naturally inside the body.
Feels less lab-based, maybe? And the cons?
Cons include the need for precise timing and being available for appointments, which can be stressful and logistically tricky. If fertility drugs are used, you have those potential side effects. We talked about hot flashes, mood swings, bloating. A big one is the increased risk of multiples. About 10% with clomiphene, but up to 30% if gonadotropins are used. That means higher risk pregnancies. And there's that risk of mild OHSS, 10-20%, if gonadotropins are used. Those severe cases are rare, about 1%.
And the cost for an IUI cycle, what's the ballpark?
An average cycle using partner sperm is around $865. If you add fertility drugs, the cost can range from $300 up to $4,000 per cycle, depending on the meds and monitoring needed. Using donor sperm adds the cost of the sperm itself, which can be several hundred to over $1,000 per vial.
Okay. So if IUI doesn't work, or if the situation calls for a more comprehensive approach right from the start, that brings us to in vitro fertilization, IVF. This is the big one, the cornerstone of advanced fertility treatment.
It really is. IVF is the heart of modern assisted reproductive technology, RT. The basic process involves retrieving eggs directly from the ovaries, then combining them with sperm in a specialized lab dish that's the in vitro part, literally in glass to allow fertilization.
Outside the body.
Exactly. Then, once embryos develop, the embryologist selects the most viable ones, and those are carefully transferred back into the uterus. It's a technique that's been around since 1978, the birth of the first IVF baby, and today it accounts for over 99% of all RT procedures worldwide.
Given how complex and expensive it is, why do people choose IVF? What situations really lead to this option?
IVF offers solutions for a really wide array of fertility challenges where other methods just might not cut it. It's a primary solution for significant ovulation problems or issues with poor egg quality where natural conception is very unlikely. It's absolutely crucial if fallopian tubes are blocked or severely damaged because IVF bypasses the tubes entirely. Endometriosis, particularly moderate to severe cases, often leads to IVF. Also, sperm count or motility issues that are too severe for IUI or long-term unexplained infertility where nothing else has worked.
And it's used in other family-building scenarios too, right?
Yes, absolutely. IVF is a key pathway for LGBTQ plus families, for individuals or couples using gestational carriers, surrogates, and for single parents by choice, allowing for genetic connections or the use of donor gametes within the IVF framework.
Before you even start the actual IVF cycle, there's a lot of groundwork, testing, evaluations. What does that involve?
Yeah, the prep phase is really comprehensive. It usually starts with extensive preconception testing for both partners. Things like antibody screens for rubella, chickenpox immunity, maybe optional genetic carrier screening for inheritable conditions.
Okay.
Infectious disease testing is standard hepatitis B, C, HIV, STIs, blood type check, pap smear for the woman. Then alongside that, there's specific fertility testing.
To figure out the exact issues.
Exactly. Testing ovarian reserve, how many eggs might be left off and using an AMH blood test. General hormone level checks like thyroid function, TSH. A thorough uterine evaluation, maybe an ultrasound or hysteroscopy to check the structure. And of course, a detailed semen analysis for the male partner.
I've also heard about something called a trial or mock transfer. Is that standard? What's the point?
A trial or mock transfer is basically a practice run for the real embryo transfer. The specialist uses an empty catheter to determine the best and easiest path into the uterus. The goal is to make the actual transfer as smooth and atraumatic as possible.
Does it actually help success rates?
That's debatable. Our sources indicate studies haven't consistently shown it improves success rates, so its necessity is something to discuss with your doctor. Understand why they're recommending it for your specific case.
Okay, so prep work done. What does the actual IVF process look like day to day? It sounds intense, like a 4 to 6 week commitment for one cycle.
It is a meticulously orchestrated process. Yeah, typically 4 to 6 weeks for one full cycle. It starts with ovarian stimulation. This lasts about 8 to 14 days. During this time, the patient self-administers daily injections of gonadotropins, those powerful hormones, to encourage the ovaries to produce multiple mature eggs instead of just one.
Right, aiming for multiple chances.
Exactly. Alongside those, other synthetic hormones are often used to prevent the body from releasing those eggs too early. This whole phase requires close supervision.
And that means lots of clinic visits for monitoring?
Yep, that's the follicle development monitoring phase. Regular visits, often every 2-3 days, for blood tests to check hormone levels and ultrasounds to measure the growth of the follicles in the ovaries. This lets the team track egg maturation precisely.
And when the follicles look ready.
Once they reach the optimal size, the patient gets the trigger shot. That HCG injection, timed perfectly, usually about 36 hours before the planned egg retrieval, it ensures the eggs complete their final maturation step.
Then comes the big day, the egg retrieval. What's that like?
The retrieval is a key procedure. It's done under light anesthesia or sedation, usually transvaginally. A needle, guided by ultrasound, goes through the vaginal wall into the ovaries to aspirate or suction out the fluid and hopefully the eggs from the mature follicles.
How many eggs do they usually get?
On average, maybe 8 to 15 eggs, but it varies hugely between patients. Afterwards, mild cramping and maybe some light spotting are common. And around this time, if using partner sperm, a sample is collected.
Okay, eggs and sperm collected. Now the lab takes over for fertilization.
Precisely. This is where the embryologist works their magic. They combine the retrieved eggs with the prepared sperm in a lab dish. Now, if there are concerns about sperm quality, or if fertilization failed in previous attempts, they might use ICSI, intracytoplasmic sperm injection.
ICSI. That's injecting one sperm into one egg.
Exactly. A single, healthy-looking sperm is meticulously injected directly into each mature egg. It dramatically increases fertilization chances in those difficult cases, typically fertilizing 50–80% of the eggs.
And then you wait to see if they grow.
Yep, the embryo development phase. Fertilized eggs, now called embryos, are carefully cultured in the lab incubator for several days.
Yeah.
By day 3, they might be 6–10 cells. The strongest ones keep developing, and some reach the blastocyst stage, a more advanced stage, by day 5 or 6.
And then choose the best ones. Embryo selection.
Right. The embryologist carefully evaluates the developing embryos based on their growth rate and appearance, grading their quality. They select the most viable-looking ones for transfer. Any other good quality embryos that aren't transferred can be frozen cryopreserved for potential future use.
Which avoids having to do the whole stimulation and retrieval again.
Exactly. Offers more chances from one retrieval cycle.
And finally, the moment everyone's waiting for, the embryo transfer. How does that work?
The transfer is often seen as the culmination. Usually 1 or 2 embryos, sometimes more, but the trend is towards single embryo transfer to reduce multiple pregnancies are loaded into a thin, flexible catheter.
Okay.
Guided by ultrasound, the catheter is gently passed through the cervix into the uterus, and the embryos are deposited. It's usually quick, relatively painless, maybe some mild cramping.
And then another wait.
Yep. The final wait. About 9 to 12 days after the transfer, a pregnancy test is done to check for successful implantation. Positive, they usually repeat it to confirm. Negative. Medications are stopped, and you regroup with the doctor to discuss next steps.
We sometimes hear about natural cycle IVF or mini IVF. How is that different from the standard process you just laid out?
Good question. It's a distinct approach. Natural cycle or mini IVF uses no or very minimal injectable fertility drugs. Sometimes it's just an HCG trigger shot or maybe even just tracking the body's natural ovulation.
Why would someone choose that? Seems less effective.
The main draws are significantly lower medication costs, which are a huge part of standard IVF expenses, and a much lower risk of ovarian hyperstimulation syndrome, OHSS. It appeals to people at high risk for OHSS, or those who don't want to create and freeze lots of embryos, or maybe women who don't produce many eggs even with high doses of drugs anyway.
But what's the downside? The trade-off?
The major trade-off is fewer eggs retrieved, maybe just 1 or 2. This naturally lowers the success rate per cycle compared to conventional IVF. So while it's less intense and cheaper per cycle, you might need more cycles to achieve a pregnancy. It's a balance.
Okay, let's talk overall success rates for IVF. We know it varies, especially with age, right?
Hugely. Age is the single biggest predictor. Looking at recent national data, like from 2021, it's really clear. For women 34 and under using their own eggs, the overall live birth rate per cycle started is around 45%. About 37% chance on the first embryo transfer.
Pretty good odds there.
Yeah, relatively good. But it drops. Ages 35, 37, it's down to about 32% overall, 28% on the first transfer. Ages 38, 40, it's around 20% overall, 18% first transfer.
Wow, quite a decline.
And it gets steeper. Ages 41, 42, maybe 10% overall. And age 43 and older, it drops to around 3% overall live birth rate per cycle started using own eggs. It really highlights the impact of the biological clock on egg quality.
But what about using donor eggs or donor embryos? Does that change the picture?
Dramatically, yes. When donor eggs or embryos are used, the success rates are much higher and, importantly, much more consistent across the recipient's age. That's because donor eggs usually come from younger women with proven fertility.
So the age factor is mostly about the egg.
Primarily, yes. For fresh donor eggs, the live birth rate is around 41%. Frozen donor eggs, about 40%. Thawed donated embryos from other couples, around 46%. And embryos created specifically for donation, about 42%. These higher rates offer significant hope when using one's own eggs isn't viable.
Are there tools to estimate individual chances?
Yes, organizations like SART, Society for Assisted Reproductive Technology, and the CDC have online calculators or predictors that can help estimate individual chances based on age, diagnosis, previous attempts, etc. They can be very helpful for setting expectations.
Given how involved and challenging IVF is, what are its biggest pros? What makes it such a powerful option?
Well, a major pro is its proven track record. IVF has been around since '78, so there's extensive long-term health data on IVF children, and crucially, no direct link to medical problems has been found. That's hugely reassuring.
Right, safety is paramount.
Absolutely. Also, the techniques are constantly improving. For example, embryo freezing techniques, vitrification, now yield pregnancy rates very similar to fresh transfers, which offers way more flexibility. And despite those old worries, recent studies show no increased risk of ovarian, breast, or endometrial cancer from the fertility drugs used. Some studies even hint at a reduced risk of cervical cancer, surprisingly.
Those are significant upsides. But IVF is also known for being incredibly demanding. What are the major cons, the downsides people need to weigh?
Definitely significant cons. The biggest are the huge cost and time commitment. It's incredibly expensive, and the monitoring requires frequent time-consuming clinic visits, which seriously impacts work and personal life. Plus, there's the heartbreak factor. Up to 20% of cycles can be canceled before egg retrieval if not enough follicles develop. That's emotionally and financially draining with no chance of success that cycle.
And the multiples risk.
Yes, the higher odds of multiples. While some see it as a blessing, transferring multiple embryos significantly increases the risk of twins, triplets, or more, and multiple pregnancies come with much higher rates of miscarriage, preterm birth, and complications for both mother and babies.
Other risks.
There's an increased ectopic pregnancy risk, especially for women with underlying infertility or older women. That's where the embryo implants outside the uterus, usually the tube, and it's not viable, sadly. And the OHSS risk from the stimulation drugs, ranging from mild bloating to rare, severe cases needing hospitalization.
And what about potential risks for the baby conceived via IVF?
This is a complex area. Some studies suggest IVF babies may have slightly higher risks of prematurity, low birth weight, and maybe certain birth defects. However, experts debate whether this is due to the IVF process itself or the underlying infertility factors like parental age or health conditions. It's not entirely clear-cut.
And just the uncertainty of it all.
Absolutely, the uncertainty. Even with good odds, IVF might not work. Facing that possibility after investing so much emotionally, physically, and financially is incredibly tough.
So let's talk dollars and cents. What does IVF really cost? We've touched on it, but let's get specific about the financial investment.
Yeah, the sticker shock is definitely real. The average cost for one IVF cycle, meaning the retrieval plus one embryo transfer, is around $22,000 in the U.S. But here's the kicker.
There's more.
Most patients actually need an average of 2.3 cycles to achieve a successful live birth.
Wow. So multiply that $22,000.
Exactly. The total average cost, realistically, often exceeds $50,000, and that base price often doesn't even include potential add-ons like ICSI, genetic testing of the embryos, or the ongoing annual fees for storing frozen embryos. It's a massive financial undertaking.
What else can drive those costs even higher?
Several things. Location matters hugely, costs vary wildly between states and even cities. The specific medications needed are a big variable. Those injectable hormones can add $3,000 to $7,000, sometimes more, per cycle.
Per cycle.
Yeah. And obviously, if you're using donor eggs, donor sperm, donor embryos, or a gestational carrier, those costs are significantly higher, involving agency fees, legal fees, donor compensation, etc.
And what about all those potential little add-on costs within an IVF cycle? The things that might not be in the initial quote.
Right, the a la carte menu almost. You've got the initial fertility assessment, maybe $250, $500. ICSI, if needed and not included, adds $1,000, $2,000. Genetic testing of embryos, PGT, to screen for chromosomal issues can be $1,800, $6,000.
PGT is becoming more common, right?
It is, yeah. Some clinics might suggest endometrial procedures like an ERA test or an endometrial scratch, adding $100,000, though the research supporting their effectiveness isn't always super strong. That trial or mock transfer we mentioned, $240, $500 again, with effectiveness debated.
And freezing and storing extra embryos.
Embryo cryopreservation itself costs maybe $1,000, $2,000 to freeze them initially. Then there's an annual storage fee, usually $350 to over $1,000 per year. And if you do a frozen embryo transfer, FET, later, that can cost up to $6,400 if it's not bundled in your initial package. The costs just keep layering up.
Okay, now the really frustrating part for many, insurance. It sounds like a total lottery.
It really is a mixed bag and often a huge barrier. Our sources highlight just how wildly coverage varies. While 21 states plus D.C. have laws mandating some kind of fertility coverage, and 15 of those specifically include IVF.
That sounds promising.
But there are often really strict rules. Maximum number of cycles covered, age limits, mandatory waiting periods before coverage kicks in. And here's a big loophole. Self-insured employers, large companies that pay for their own health plans, are often exempt from these state mandates.
So your state might have a law, but your specific company plan doesn't have to follow it.
Exactly, which means it is absolutely critical, I can't stress this enough, to meticulously review your specific insurance policy. Call them, ask detailed questions, get things in writing. Assumptions can lead to devastating financial surprises down the road.
So given these huge costs and patchy insurance, what can people actually do to manage the financial burden? Are there strategies?
Yes, people get incredibly resourceful. One avenue is actively looking for grants. There are private foundations, some nonprofits, even some government-funded grants specifically for fertility treatment, and crucially, these don't need repayment.
Free money, basically.
Essentially, yeah, though competitive.
Yeah.
Many clinics also offer internal payment plans or can connect patients with local charities or medication assistance programs that offer discounts. There are also specialized fertility financing companies offering loans specifically designed for these treatments.
I've also heard about people traveling for treatment, like medical tourism, almost. Is that a real option?
It is for some, yeah. People consider traveling to other states or even countries. Mexico was mentioned by one community member where costs might be significantly lower, even factoring in travel. But, and this is a big but.
Quality concerns.
Exactly. Dr. Hackman, a fertility specialist, strongly advises that if you're comparison shopping, you must thoroughly check the clinic's quality. Look at online reviews and, crucially, check their success rates on sites like sart.org. You don't want to end up cutting corners on qualitative care just to save money. That could backfire badly.
This whole financial discussion raises a really powerful question, doesn't it? When access is so heavily dependent on cost and insurance luck, what does that mean for equitable access to family building? It feels less like healthcare and more like a luxury good sometimes.
That's a profound and necessary question to ask. The immense financial barriers undoubtedly create huge inequities. Who gets to try to build a family this way often depends on their zip code, their employer, or their bank account, not just their medical need. And the stories from the BabyCenter community show incredible resilience, people leveraging refund policies, diligently hunting for medication discounts, advocating fiercely with employers, exploring international options, but it also shines a harsh light on the systemic gaps. It really underscores that while the medical technology is amazing, the social and financial structures haven't kept pace to ensure fair access to what is, for many, a fundamental human desire.
It's a lot to think about.
Yeah.
Okay, shifting gears slightly, beyond the finances, lifestyle factors also come into play. Let's talk about weight, BMI, and fertility, especially with the recent explosion of drugs like Ozempic and Mounjaro.
Right. This is a really timely and complex topic, especially with, societal pressures around body size. The rise of these popular weight loss drugs, Ozempic, Wegovy, semaglutide, Mounjaro, tirzepatide, has definitely added a new layer to the conversation about body weight and fertility.
So how does body weight actually impact fertility? What's the science behind doctors often recommending weight management?
There's a definite link. A higher body mass index, or BMI, classified as overweight at 25-29.9, and obese at 30 plus is clearly linked to irregular menstrual cycles and problems with ovulation. This can make getting pregnant naturally much harder and take longer.
Okay, impacts ovulation. What about pregnancy itself?
Elevated BMI is also associated with higher miscarriage rates and increased risks during pregnancy. Things like gestational diabetes, preeclampsia, that dangerous high blood pressure, other hypertensive disorders, these are serious risks for both mom and baby. And even with treatments like IVF, patients with higher BMI sometimes have slightly lower success rates.
So doctors encourage weight loss for those reasons.
Yeah.
Some clinics even have BMI cutoffs for treatment, right? Which feels complicated.
It is complicated. Fertility experts often encourage weight loss through lifestyle changes or now potentially medication for all those reasons. And yes, some clinics do have BMI requirements before they'll offer treatment. It's important to acknowledge, though, that for many people, underlying conditions like PCOS or thyroid issues can make weight loss incredibly difficult, adding another layer of frustration.
So how do these new drugs, Ozempic, Wegovy, Mounjaro, actually work? And why the huge buzz?
They're injectable meds that mimic natural gut hormones like GLP-1 and GIP from Mounjaro. These hormones do things like lower blood sugar, make you feel really full, and reduce appetite so you eat less. They were first developed for type 2 diabetes.
But the weight loss results are dramatic.
Really dramatic. Studies show semaglutide users losing nearly 11% of body weight in 6 months, tirzepatide users losing 15% or more over 72 weeks. These results are so significant they're seen as almost a medical alternative to bariatric surgery.
And the demand is through the roof, lots of off-label use.
Huge demand leading to shortages. Only Wegovy is actually FDA approved specifically for weight management in certain BMI groups, but many use them off-label for general weight loss or even for conditions like insulin-resistant PCOS where they can help metabolically.
Okay, here's the crucial part for our listeners thinking about pregnancy.
Yeah.
Are these drugs safe for fertility and pregnancy? What do we know?
This is where we need extreme caution. The prescribing info for all 3 drugs explicitly states they are not recommended for pregnant individuals. Full stop.
Not recommended. Okay.
Experts strongly advise stopping these meds for at least 2 months, some say even longer before trying to conceive. Give the drugs time to fully clear your system. And if you're taking them and are of reproductive age but not planning pregnancy, strict effective birth control is essential.
Why so cautious? Is it the lack of data?
Primarily, yes. There's limited long-term safety data, especially in people of reproductive age without diabetes and, crucially, during pregnancy. These drugs are relatively new. Ozempic approved 2017, Wegovy 2021. As one expert put it bluntly, we don't know what the drug does to a growing fetus. There just isn't enough research yet.
Are there concerns beyond the drug itself, maybe about rapid weight loss?
Yes. Significant or rapid weight fluctuations can sometimes disrupt hormonal balances and menstrual cycles, potentially making conception harder temporarily. There's also concerns similar to after bariatric surgery that rapid weight loss could lead to nutrient deficiencies. And as another expert said, you don't want to be malnourished when you're trying to grow a baby. It could potentially increase risks like miscarriage, preterm birth, or smaller babies.
And breastfeeding.
Also not recommended. We don't know if the drugs pass into breast milk, and significant weight loss can negatively affect milk supply anyway.
So it sounds like these drugs are powerful for weight loss, but their role in the fertility journey needs way more research and extreme caution right now. How should we think about weight and health more broadly then?
We need a more nuanced view. BMI is convenient, but it's an oversimplification. It doesn't tell the whole story about health. And while weight loss can restore ovulation for some, a big 2022 study in PLOS Medicine looked at women with high BMI and unexplained infertility. It found that weight loss interventions before fertility treatment didn't significantly improve their fertility or live birth rates.
Really, no improvement in birth rates.
Not significantly in that study. However, weight loss is consistently linked to better overall pregnancy health outcomes, fewer complications like gestational diabetes or preeclampsia. So it's complex. The widespread use of these new drugs really just highlights the urgent need for more data on their safety, specifically for fertility and pregnancy.
Okay, well, weight is clearly complex and evolving. Exercise seems to have much clearer guidelines during fertility treatment.
That's true, yeah. For people actively undergoing IVF or IUI, the general guideline from specialists is usually a pretty confident yes. It's generally okay, often even encouraged, to maintain your regular exercise routine.
That must be a relief for many. But there's a caveat, right?
Absolutely. The big caveat is you must get the green light from your healthcare provider first. And it assumes you don't have any underlying health conditions that would specifically make exercise risky during treatment. Always check with your doctor.
So if the doctor says okay, you don't necessarily need to stop working out.
Generally, no. Dr. Sasha Hackman, a fertility specialist in our sources, states pretty clearly that as long as your provider approves, continuing your normal exercise routine is usually fine. For many people, exercise is crucial for managing stress and feeling good, especially during such a demanding time. So being able to continue, with guidance, is really valuable for overall well-being.
Makes sense. Maintaining physical health is important, but just as crucial is looking after emotional well-being, knowing when to get support, or even knowing when it might be time to hit pause on the whole treatment process.
Absolutely. Navigating fertility treatments effectively demands a really proactive, holistic approach, mind and body. Our sources consistently stress how important it is to learn everything you can about the process before you start.
Knowledge is power.
It really is. Talking openly with your doctors, understanding each step, each medication, each procedure that builds confidence, demystifies things, and can seriously reduce anxiety.
So it's about preparing yourself mentally and practically.
Exactly. Strategic planning on all fronts. Checking that insurance coverage meticulously, setting a realistic budget, but also proactively exploring support groups before you even begin treatment.
Get your support system in place early.
Yes. Having peers who truly get it and having access to counselors lined up can make a world of difference when you hit those inevitable bumps in the road, the uncertainty, the disappointments. It's a vital emotional safety net.
And if the emotional toll gets really heavy, beyond what friends or support groups can handle.
If depression, anxiety, or just overwhelming distress starts seriously impacting your daily life, your relationships, your ability to function seeking professional help isn't just a good idea, it's crucial. Find a mental health counselor, therapist, or psychiatrist who specializes in infertility.
That specialization again.
It matters. They understand the unique pressures, can help navigate relationship strains, process the emotional weight of medical choices, and equip you with strategies to build resilience and cope effectively. And always remember, if thoughts of self-harm arise, the National Suicide and Crisis Lifeline at 988 is there for immediate, confidential support.
What about day-to-day coping? Practical things people can do.
Several things. Informed empowerment, knowing your situation, your plan, your options, gives a sense of control. Open communication with your partner regular, honest check-ins about feelings, fears, progress keeps you connected. Actively using relaxation techniques, meditation, deep breathing, muscle relaxation helps manage stress in the moment.
Calming the nervous system.
Exactly. And sticking with those consistent healthy habits, exercise, if cleared, healthy diet. Prioritizing sleep supports your overall well-being through a demanding time.
And addressing the sexual stress we talked about earlier. Turning intimacy back into connection, not a chore.
Super important. Acknowledge the pressure conception goals put on sex. Maybe intentionally have fun sex during non-fertile times, totally separate from the goal. Or explore other ways to be physically intimate and connected that aren't just about intercourse. Nurture the relationship itself.
While all these strategies help navigate the journey, sometimes the bravest choice is knowing when to pause, take a break, or even stop fertility treatments altogether. That must be an incredibly hard decision.
It's arguably one of the most difficult and profoundly personal choices anyone makes on this path. There's no single right answer. Every person's journey, their reserves, physical and emotional, are unique.
So it has to be a personal calculation.
Absolutely, and it should always be made in close consultation with your doctor, weighing your personal situation, your health, your emotional well-being against continuing treatment. It's also helpful to be aware of how deep emotional states like depression or anxiety might be influencing the decision. Try to make it from a place of clarity, not just burnout.
So really listening to your body, your mind, your relationship.
Exactly. The infertility journey can be an emotionally exhausting marathon. It leaves people feeling anxious, depressed, vulnerable, uncertain, prioritizing mental and physical health, seeking support that's paramount throughout. And our sources end with a really vital reminder. There are many, many different paths to parenthood.
Right. Treatment isn't the only way.
Not at all. While the journey might be complex, unconventional, unique, it can ultimately lead to incredible joy and the fulfillment of building a family, even if it doesn't follow the route you first imagined. Success isn't just one specific medical outcome, it's creating and nurturing a family, however that happens.
Wow, what a truly comprehensive deep dive we've had into the world of fertility treatments. We've really unpacked so many options from the initial steps like medications and surgery,
Mhm.
all the way to IUI, IVF, and those third-party options like donor conception and surrogacy.
And we shone a crucial light on those often overwhelming costs, how people navigate insurance, the creative ways they manage financially, and maybe most importantly, we explored that immense emotional and psychological side, stress of holistic well-being, managing lifestyle factors, and finding strong support.
What really strikes me is that even as the science keeps advancing, getting more precise, the decision-making remains so deeply personal, doesn't it?
Absolutely. It requires this constant balancing act, financial realities, physical demands, emotional resilience. It's definitely not one size fits all. Continuous, open conversation with a compassionate fertility specialist is just key to getting a plan that truly fits you. And as we've seen, this journey towards parenthood through fertility treatments is one defined by incredible hope, amazing resilience, and often really significant sacrifice. If we connect this to the bigger picture, it makes you wonder, doesn't it?
How so?
Well, how might society evolve? Beyond just the medical side, how can we provide more comprehensive, more equitable, and more emotionally sensitive support for everyone navigating these incredibly personal and challenging paths to building their family? How do we shift from treating infertility like a private struggle to recognizing and supporting it as a shared human experience that deserves broader understanding and resources?